Start.
In progress.
There we
Awesome.
go.
Hey,
Let's get this party started.
want to thank everybody for joining us. My name is Lynn Pensick. I am the South Jersey representative for Nobel Biocare. And we're going to have Kendra advance the slides. And with Nobel Biocare, we help you provide more care to more patients better. I reached out to Kendra about this course in treating or billing medical insurance for cases. And this is just an exciting opportunity for us to find more ways to provide better care for our patients. With Nobel Biocare, we try to help with improving workflows to reduce patient visits and help produce more predictable outcomes. Together with SprintRay, Biocare, and the owned by the company Invista, Nobel Biocare helps us provide more care to more patients better with digital workflow. To learn more about how all our companies work together, please join us at the Invista Summit in February of 2023 in Las Vegas at the Bellagio Hotel. This is a must-see event if you are a provider of dental implants, and we will show how all our companies work together with the latest technology and how to provide better care for our patients. I'm going to go to the next slide. We have tuition promotions that we bundle with purchases of dental implants. If you do not actually place dental implants surgically, we do have options for restorative doctors. The new N1 single drill implant system will be launched later this year. This is a radical change in how we provide care to our patients. With slower speeds, we'll have less vibration. And this is a drill technique that involves a directional and a single osteoshaper. The single drill protocol has been proven effective in promoting faster healing time for earlier loading. Together with SprintRay, we're giving you the ability to contain your costs and actually print mouth guards, temporary crowns, and surgical guides in office. With this and our DTX program together, we're able to reduce costs and provide better care for our patients and contain all these workflows in office. This is an example of our DTX program and how to provide an immediate provisional. We have with the DTX program the ability to plan the surgically placed implant, design the crown, to use as the immediate provisional, which serves as a healing abutment, a customized healing abutment, which will help produce a better aesthetic result to the papilla. Go to the next slide. And here's an example of how the temp shell, the immediate provisional crown, is placed onto the dental implant and created a screw retained healing abutment. This is the workflow. We'll give a little time if you want to enlarge this picture to see initial treatment of patient, diagnostic, case planning, and surgical design for the surgical guide. Second row is the extraction site, the placement of the implant. We have the restorative platform on the third line, the design of the temp shell, the fitting of the temp shell, the placement of the temp shell to the temp coping onto the crown, the screw retention of the temporary crown. And here we have a patient, day of surgery, immediate stability, primary placement, immediate stability with a temporary crown out of occlusion being placed. The other option we have is to have the patient leave with a retainer. We know that patients lose retainers. Not all patients are excited about having retainers. This is one more treatment option when the candidate presents themselves as a good candidate. Next slide. DTX Studio, DTX Go, is our communication portal. And this is how we can collect all our data for case diagnostics and treatment planning. Together with DTX Implant, it helps us provide the treatment planning. And with DTX Go, it gives us the ability for a surgeon and a restoring doctor to communicate in live time in how we case plan and make sure that we're both on the same page, that we like the restorative outcome and that the surgeon has the appropriate needs for their placement. Let's go next.
Every once in a while, it doesn't want to work for me.
These things happen. Here we go. And with DTX Implant, we have the ability with an app that you and your patient can download to your Apple device, phone, iPad, and it gives the ability as a consultation tool in a format that's easy to work with. So, along with classes like this, Nobel Biocare has a women in dentistry group in New Jersey. The neat thing about working with a female study group is that for every hard science class we offer, we also have another class on work-life balance. Our last class was actually on acupuncture and pain control. So it's a little different of a study club. And if you're interested, please reach out to me. What's new with Nobel Biocare is we have 2 new surfaces, TiUnite and TiUltra and Zeal. These 2 new surfaces are designed to optimize tissue integration. What's the benefit of TiUnite and TiUltra and Zeal is a faster growth of human epithelial cells. And with this, I'm going to have you advance. We have less bacteria because the surfaces are smoother. Instead of creating a rough surface with sandblasting, with anodizing, we're creating a minimally rough surface with a higher oxygen level. With that, we're getting faster bioprotein attachment, less bacteria because of the minimally rough surface, and lower bleeding upon removal of abutments. We're having healthier tissue, more keratinized tissue, and stable bone levels. From a restorative aspect, our new zirconia bridge gives restorative freedom. It gives us the ability to restore direct to fixture with the Brannemark, the trilobe, and our conical connection. It gives the ability to restore to a multi-unit abutment. And if we need more angulation change, we can place a angulated screw channel on top of the multi-unit abutment. It'll give us 50 degrees of angulation if needed. What's nice about the zirconia bridge is it gives us complete restorative freedom. Please reach out to your laboratories to see how they're working with this restorative solution. And now I would like to, I'd like to bring in Kendra as our presenter tonight, and I'm going to have Kendra introduce herself.
Excellent. Thank you so much, Lynn. I'm really excited to be part of this partnership with Nobel. Just so you all know, I'm going to bring this up while I'm talking about Nobel and thanking them. I am not being paid by Nobel to promote their products or anything like that, as well as any other companies during my presentation. This has just been an amazing partnership with Lynn and great discussions. I just feel it is such an exciting time in dentistry for all of us. I just can't even express how thankful I am to be able to be here tonight with Nobel and as a partner and moving our profession forward. One thing I want to let you all know as we go through tonight, Lynn's going to be looking at the chat for any questions. Please do feel free to put any questions in the chat as we go. If you are thinking something, somebody else is probably thinking the same thing. I like this to be very interactive. I don't want to be the one talking for the next hour. So feel free to, put something in the chat if you're thinking about it, and we'll answer questions as we can along the way. I really like this to be as casual and as interactive as possible tonight. So a little bit about myself. Lynn decided not to do an actual professional introduction, which I think is great because that fits my style better. I'm a registered hygienist. I had to do the math this morning to see how many years has it been. I graduated in 1993, so 29 years I've been in dental hygiene. With my experience as an assistant prior to that, I would say I'm probably closer to 35 years in our industry. So I've been around a little while. I've done a lot of different things. I actually, right out of hygiene school, I started working with a prosthodontist, which I loved. At that time, we weren't even really placing implants. This has come so far. It's pretty wild when you think about 1993 to 2022, all the technology that we have. So I started with a prosthodontist. I then moved to a periodontist. I loved specialty dentistry, and I just continued to have amazing mentors that allowed me to grow in my profession. It's been an amazing journey, and that's really the road is long for me. I mean, over that many years, I've done a lot of different things, from sales to consulting to practice management, and I've ended up here. And really how I ended up here was, going to seminars on medical billing. I did that 4 times with a doctor named Dr. Chris Ferrugia. And finally, after watching these seminars and seeing people it was either the doctor and the assistant, or the doctor and an admin person, or maybe just the doctor, maybe just the admin person. It was like I could see after 2 days of these meetings, which were fantastic meetings, and I think they're very, very valuable to go to these 2-day meetings. I just felt like everybody was overwhelmed and didn't know how to take it to the next level. So I finally approached Dr. Frugia and I said, hey, have you ever thought about implementation? Because I see a really big gap in this process of learning about medical billing. And he said, I've thought about it. It's not something I want to do. I'm a speaker. That's what I want to do. And so I said, hey, would you be my mentor? I would love for you to be my mentor and build a relationship with you. We have separate companies, but I built my business on this gap that I was seeing in our industry. So TIPS became a real thing, and it really means Tandem in Practice Solutions for Dental Medical Billing. And I really try to intertwine oral systemic health into this because I think that's very valuable. I think it's very real where we are here in 2022. And I want to provide more for patients. I was also seeing a very big gap in third-party billing companies where I felt like there was some unethical things going on. And so, my goal is to be hands-on with my support and my implementation, and building with, making sure that we're being totally ethical, we have high integrity and transparency, all leading to success, not only for our practice and our doctors, but for the patients as well. As a hygienist, it was very important for me to be on the other side of clinical. I'm not able to practice clinical anymore. So now I'm on a different side of helping patients in a different way, I'm being a different kind of advocate. And that's very important to me. And that's really where I focus all my attention, is being an advocate for that patient, because they do have benefits for the things that we do in our practices every day. And now we can bring that to them. So advocacy for me for patients is really important. And I feel like when you are centric with that, the rest will follow for our practices. In all of this, I believe tonight, one of my goals is to shift your mindset into dentistry and what we are. I personally don't think that we value ourselves enough as medical providers. I think we need to shift our mind, and we need to wrap our heads around medical billing and what it means in a dental practice, and what it means to collaborate with our medical professionals. So I'm hoping that we can shift our mind into a different place and understand what it is that we can really bring to our patients and our profession, as well as the medical community. Dental insurance, if you get nothing out of tonight, the one thing I want you to get is that dental insurance is truly a supplement. It is not meant to be a true benefit or insurance plan. I was just recently at a practice in Oregon, and they call it a coupon. I love that, because that's really all it is. It's a coupon policy. It's like my Colonial Life that I have for accident and disability. It's a extension from my medical insurance. We really need to look at it as that. We have currently allowed dental insurance to dictate everything about our practice, including our fees. And that's not good. I'm hearing more and more from people about how fees are being dropped and to a lower level when, we've got, our costs are rising astronomically this last year, especially with all the PPE. So we really need to be looking outside of dental benefits as an opportunity to bill. I'm going to get this right out of the way, because one of my biggest questions is deductible, but all patients have high deductibles. It's not always the case. And quite honestly, there are a lot of codes that don't even go towards deductible. Deductible is just a word. So I do find that a lot of times higher deductible plans have less benefits. So just like with dental, there are good policies as well as bad policies. So, you know, but we can't let deductible dictate everything that we do. I will say that when we call policies and we get our insurance breakdowns for patients, they often will say, after your deductible is met, this is what we will pay. That's very, very common standard answer that we get from the reps that are giving benefits out. They really have no idea if the codes that we are going to be billing are going to apply to deductible or not. So deductible is a word. Don't get hung up on deductible. I've got some great examples here. Here's an opportunity with sleep. And while we're talking about surgical stuff, this is just a great way to show you that on the same data service, all of our diagnostics for sleep. So we had a tomographic study, basically a CT. We had an orthopanogram, which is a pan, our evaluation, the pharyngometry, I have the hardest time with that word, lateral ceph and rhinometry. All of these things were billed out and nothing went towards deductible. You do see a few things go, you see everything had some co-insurance, and they also still got payment. A lot of people aren't even billing this out as part of their sleep diagnostics, but that is an opportunity in your practice. There are so many opportunities in your practice. This is just one of them. But nothing went to deductible. So that's a great example. The next slide is basically the home sleep study, which was billed out on the same day. Now you see that going towards deductible plus no co-insurance or copay. So that's actually complete opposite of what I just showed you. It's on the same exact data service. So great analysis basically of not everything goes towards deductible, because it doesn't. And you often see that with the evaluations not going towards deductible. Often it's going towards you may have a copay. I know, like my insurance policy, we have a copay, and from that we have, the rest goes as a payment to the doctor. So very, very common to have copays or coinsurance, or sometimes nothing going to any of those three things. Here's one big thing that we need to start getting our heads wrapped around. As a healthcare practitioner, we are specifically looking at one part of the body. We're looking at the head, the neck, the TMJ, the teeth. We're not just counting teeth. We're looking at the oral cavity. We're looking for head and neck cancers. We're looking at all the surrounding structures of the mouth, not just counting teeth. This makes us a medical specialist. That's what we have to, we have to label ourselves differently. We're not just a dentist. We're not just a hygienist. We are so much more than that. And it's, like I said, it's an exciting time in dentistry. And I would love to see more, even people's websites, not saying, here's our dentist, but what about our oral care physician? That's really what we all are. So, let's start labeling ourselves different, because to me, dentist equals teeth. Hygienist equals a mouth maid. We are so much more than that in this day and age. It even goes back to the Mail brothers. In 1910, they were already talking about how the mouth was connected with living longer, and that it was truly the gateway to good health. It is crazy to me that so many practices, so many doctors and patients still don't know this connection between oral systemic health. It's 2022. We have so many resources to show that there's a connection between oral systemic, and I sometimes am a little flabbergasted by that. Anyway, we have all the research. We know that within 1 minute, microorganisms the infected microorganisms and infection can trail through the rest of the body and reach all of our organs and blood capillaries. We have this data. We are so much more than just dentists or dental hygienists or dental assistants. We also know that within 30 days, an oral event, a vascular event, I'm sorry, can happen because of what we've disrupted in the mouth. That bacteria is still streaming through the bloodstream. So again, we have to start looking at, we are more than just dentists and dental hygienists. And why and how can we bill to medical? And I often get this question, can dentists bill to medical? Yes, we can. In fact, we can bill to medical and dental. So that's amazing. And we've got this Affordable Care Act that actually says that they can't discriminate against our provider type. In fact, I just had a client today. We had gotten an EOB back stating, hey, we don't pay for this dental service. Really? That's interesting. And it was an exam and a CT, I believe. And I sent a nice little letter back stating, hey, you know what? You're discriminating against us, and that's illegal to do. So guess what? A payment showed up today, just today. So that was a great win for us. It was exciting to see, because that this statute does work. If you are having claims being rejected, this is one way to fight that. What I can say, there are some states, one of them being Michigan, unfortunately, that one of their carriers is doing this all day, every day. They will only pay an oral surgeon, which is, I don't even know what to say about that. Really, what Michigan needs to do is their dentists need to stand up, and they need to fight that insurance carrier for reimbursement for the things that they do, because not only oral surgeons are doing a lot of these procedures anymore. More general dentists are getting advanced training on how to place implants, how to do bone grafting, how to do TMJ therapy, Botox therapy. There's more to, there's just more people doing these advanced procedures. So it just isn't even fair that Michigan and that insurance carrier is doing that. It's very hard to bill in Michigan. I do have one question there. Xenia, do you have to bill the patients for deductible if a claim is processed out of network? Yes, you do. That being said, if you are billing to both medical and dental and you are in network with dental, you have to follow the dental guidelines, the dental carrier agreement, I guess you could say. So whatever you're contracted with, you'd want to make sure that you know your dental contract and what that says. It may disclude you from being able to bill the patient's deductible, copay, or coinsurance based on what dental contract you're under. So it depends. If you're in network with dental and you're billing to medical and dental, there's lots of different scenarios with that. So opportunities, what are all of our opportunities in medical billing? Evaluations. So hygiene, if you're doing a head and neck evaluation, you can bill for that. If you have an emergency evaluation that comes in, you can bill for that. Really, just about any evaluation that you're doing, surgical evaluations, you can bill for that. Our radiology. Now, when I say radiology, really, medical is going to be looking for CTs, lateral ceph, Panorex. Once in a while, when we have trauma, we can bill for PAs and things like that. But medicine is looking for a bigger picture. They're not looking at teeth, and a PA or a bite wing is going to be looking at teeth. So we want to stay away from that unless it's trauma related. Surgery, they're going to cover surgical procedures and the things that go along with that. And I'll talk more about that in a little bit. TMJ, sleep, trauma. We also have frenectomies, Botox, seeing some great reimbursement with Botox. Biopsies, fluoride varnish, advanced oral cancer screening with like Velscope or oral ID, and systemic conditions that are contributing to oral disease. and destruction. So surgical diagnostics and treatment, I want to focus in on that a little bit more because, you know, we're talking implants tonight and other things, but I want to talk about one thing that I see as a gap. I see things getting billed out on the surgical side. However, what I don't see getting billed out is the evaluations. What about all the evaluation and prep that we're doing on all of these cases, on these surgical cases? I see that with sleep as well. So evaluations, are we doing an orthopanogram, a CT, those things as part of our diagnostic portion of this case planning can be billed to medical. What about our surgical stents? Yes. How about grafting? Yes. The implants, yes. Interim prosthesis, yes. That flipper, hopefully Lynn gave you some other options for that. I was pretty much blown away when I learned that they can actually make something a temporary type solution without needing to have a flipper. I think that's pretty cool. Same day. Final prosthesis. So all of those things in surgical diagnostic and treatment planning can be billed to medical. Now, again, when I say that, it's going to be based on the patient's policy and the things that are covered. So we have to do our background checks to find out what's covered, if it needs a prior authorization, all of those good things. That being said, the biggest gap that I see in between medical and dental is right here in medical necessity. What does that mean? Medical necessity is based on, it describes basically what treatment we're doing and why we're doing the treatment. We're going to be using medical diagnosis codes. This is not something that we are taught in school. It's not something that they're teaching yet in school. They're not teaching diagnostic coding, and that is a huge gap. That is our golden ticket right here. Right here, this is it. Diagnosis codes are imperative for a medical claim. So you need to be learning what diagnosis codes are. So we're gonna do a little bit with that tonight because it sounds intimidating for most people, but there's not that many codes that we truly use in dentistry. Every specialty has kind of a code set that they use that's very common, but it's something that we need to learn. And there, just an FYI, there are no dental diagnosis codes versus medical diagnosis codes. They're all medical diagnosis codes. It's all one code set. There's, unlike procedure codes, where there's a dental procedure code, CDT, and there's medical CPT codes. Those are different code sets. But when it comes to the diagnostic part, it's all the same. Now, medical necessity, what does that mean? Here's Medicare's description of that. It's healthcare services or supplies needed to prevent, diagnose, or treat an illness, injury, condition, disease, or symptoms, and that meet accepted standards of medicine. It has to be medically necessary. It has to make sense. You break your leg, you break your leg, you go to the ER, they give you crutches. They're going to pay for those crutches because you just broke your leg. It makes sense to them to pay for that. So think of, when we're talking about medical billing, think about the things that you've encountered on the medical side. It's so different, but it's not. Think about how we react to medical. We don't question medical. One thing that just popped into my brain was when we go to a medical doctor, we never ask how much it's going to cost. When we go in for a surgical procedure, we have no idea what we're going to come out with for bills. When in dentistry, what often happens is we're giving our patients to the penny what they owe. That's very, very common. Again, we've allowed dentistry to kind of dictate everything about what we do. So again, it's different, and we got to wrap our heads around this. Sorry, I got off on a tangent there. So here's one thing that's amazing to me. The ADA form has had a place for diagnostic codes since 2012. I don't see anybody using that box. I'm not sure if dental, if you started putting diagnosis codes in there, if they would even know what to do with them. I'm really not sure. It's there, but I don't see it being used. I keep hearing in the dental industry, dental insurance keeps asking us for more and more and more information. Maybe if we use diagnostic codes, they would understand why it is that we're doing what we're doing. If you think about it, we submit claims all day long to dental insurance without any reason why we did it. Diagnosis codes explain that reason. So maybe if we use diagnostic codes, they would understand why it is we're doing what we did, and maybe wouldn't ask for as much documentation. I'm not sure. I just think it's crazy that those have been there since 2012, but nobody is doing anything with it. Now, what's different, excuse me, I'm going to grab a glass of water here. What's also different is the claim form that we use in medicine. There's actually 12 spots for diagnostic codes, and it's a very different form than what dentistry uses. Similar but different. It's a CMS 1500 form versus the ADA form. And there's 12 spots for diagnosis codes. So there's definitely more than 4. In diagnostic coding, what we need to start keying into is pain. Does the patient have pain? That's one of the first codes on my list when I submit a claim. Did the patient come in pain? There are codes for pain, atypical facial pain, jaw pain. There's all sorts of different pain codes. But what I often see, I think in dentistry, we are so used to seeing pain that we don't even document it. And we're going to talk about documentation. Did the patient come in an emergency? Did they blow up your schedule because they were in pain? We need to document that. If the patient has had cancer, have they had chemo or radiation? We want to document that because that can destroy the mouth. Did they come in trauma? What happened with that trauma? Because we can submit that to medical insurance. Do they have impaired function? If they're in pain, they're clearly impairing function. They can't function because they're in pain and they can't chew. Do they have a sleep problem? Are they sleep breathing disorder? Do they have bone atrophy? I don't know if anybody that probably doesn't have atrophy except for kids. Do they have dry mouth? I think as hygienists, we get so used to seeing patients with dry mouth that we don't document it. But there are diagnosis codes for that. Do they have a sinus problem? Are there defects? Again, is there a medical history of systemic conditions that are creating problems within their oral cavity? In fact, there's almost over 72,000 diagnosis codes, which is crazy. I think it's even larger than that. It's kind of like every year they go through the CDT codes and change them. This is the same thing with medical and with medical coding. They change codes, they add codes. There's a lot of codes. There's a code for just about everything. Here's where I'm going to ask you guys to do something. I want you to, if you're not on your phone, I want you to go to the website icd10data.com. And this is where I go to look for codes. It's free. You can look up just about anything. And I want you to type into that, sucked into jet engine. And I want somebody to put into the chat what you get. I'm going to give you a second here to look that up. Sucked into jet engine. The sad thing to me is that this has happened multiple times, apparently, in order to have diagnosis codes to go along with it. Because there are. Anybody? Looking at the chat, I don't see anything. What are you seeing out there, guys? I want you to recognize how easy this is to look up a diagnostic code. Anybody going to give me one? Aha. Zinnia, yes. Let's look at this. This is what you'll get. Sucked into jet engine. And it's V97.33. Now you're going to notice there's 4 different codes there. This is a trauma. This is obviously a trauma. And the top, when you look at these, when you look at the top one, it has a red arrow. That means that you can't use that code alone. It needs more definition. So you're going to see the next one is sequela. So well, let's go down to initial encounter. That would make sense, right? Has an XA by it. And that means that it was initial encounter and the patient showed up at your office. What about they have a subsequent, say they come in today, that was the initial encounter, they come back for another visit, that's a subsequent encounter, so it'd be XD. And say 5 years down the road, they have a tooth that needs a root canal because of the initial encounter. So that would be your sequela. Those all have green arrows, and those are codes that you can use on a claim. But again, I want you to see that using ICD-10data.com, and there's other resources. What I can tell you with ICD-10data.com is if you do a lot of shopping online, it was very hard for me to get this image with just that bar, because what happens is a lot of places that you like to shop start sending you ads through. The more that you use this tool, you'll get your pop-ups that you shop frequently for. So just know that. So let's look at this. This was a patient. We actually got Medicare to pay for bone grafting, and she needed multiple rounds of bone grafting. And this was, look up severe atrophy maxilla, and you're going to get a code. This is how simple it is. K08.26. Now, anything with the oral cavity is going to start with a K. I try to leave those codes, like if I have other codes I can use that are not a K code that screams dental, I try to use the others. But this is obviously one that we use a lot, and we use it a lot with implants and grafting. So severe atrophy of the maxilla. There's going to be a different one for minimal atrophy and moderate atrophy as well. Here's one of the mandible, very severe, same patient. She needed a lot of grafting. I can't even imagine this poor woman if she had her grandchild on her lap. She had her grandchild on her lap and was bouncing, and if she got head butted, I can't even imagine. She was definitely, I mean, look at that. Can you imagine? She's at risk for pathological fracture. Her bone was so thin. She had such severe atrophy. Here's K08.23. That's severe atrophy of the mandible. So it's very easy to look up codes. And like I said, there's a code for just about everything that you can think of when there's 73,000 codes. I don't want us to dismiss systemic conditions. This was one of my patients, Brad. At the time of this actual picture, Brad was, I believe, 21 or 23, something like that. Brad was not supposed to live past the age of 9. And you can see that he had some crowns in the front. He actually had those done at Mayo Clinic. Brad had more conditions than I had ever heard of, and things that I had never heard of. He had had pancreatic transplants twice. I mean, he had so many different things. I can't even imagine the medical bills that his parents had for him. And at 21 or 23, Brad was actually able to get off of a feeding tube. But you can see at his posterior teeth, he had nothing to function with, and his lowers were just the same. We were able to get all of his, and some of you might think, gosh, we might just extract those teeth, but you know, he's only 21 years old. He's got his whole life, hopefully, ahead of him. we were able to do gingivectomies and get that covered, as well as crown core and build up and crowns. And finally, he had teeth to function with. But I don't want you to dismiss those things, because that's a huge opportunity for patients who are struggling. And Brad's family was just elated because they really didn't have the money to pay for all the restorations that needed to happen there. That was a large case. So it was really cool to see him obtain teeth that he could finally function with, now that he could actually be off of a feeding tube and eat real food. What I do know, again, I think I've said it, a claim is going to be denied from medical if you do not use a diagnostic code. I've often seen that where clients have said, we've tried medical billing, this doesn't work. It's because, and I've seen their claims, they didn't have a diagnostic code on the claim. So you will get a denied claim if you don't have a diagnosis. In fact, my program that I use for my clearinghouse, if you don't have a diagnostic code, it won't even accept the claim. I've got a question here. Many offices are using Arrestin. How is that billed? It can be billed. I have a lot of offices that use the RX program through Arrestin, and it's the same way. It's billed through the patient's pharmacy benefits. I don't have any offices that are doing that. They're using the RX program. That's working well for them, but it's the same thing. It goes through their pharmacy benefits. Let's talk about evaluations, because really that's where it starts, is the evaluation leads to the diagnosis. Let's look at Jack. As a hygienist, it's really hard to not focus on those teeth, because you're going to have to hold them in place. He's got such severe atrophy. He's got a lot of things wrong with his mouth. And it's hard to look past the teeth, but we need to start looking past the teeth and start looking at the bone, because that's what we're going to build to medical. Medical doesn't care so much about the teeth unless it's trauma or if it's a systemic condition. They aren't going to pay for extractions unless it has some type of systemic condition associated with it. So we got to look past the teeth. It's really hard in this image to do that. And as a hygienist, it's really hard to not want to start treatment planning all that we could there. But we need to move past the teeth and think about medical as well as the teeth. We have so many tools in our toolbox, whether it's on the hygiene side or the doctor's side. A lot of it does start in the hygiene chair, but what's surprising to me is all that we do, we schedule an hour with our patients, but we are not reimbursed. We are not reimbursed as a specialist or for our expertise by dental. When we look at evaluations, think about this. In dental, say we have a patient that comes in for a routine evaluation. We use a D0120. That's a very common code to be used. I would say in hygiene, the codes often are not being used appropriately for hygiene and for our evaluations. We maybe aren't always picking the best code, but we're only reimbursed what we're reimbursed for that 0120. It doesn't matter if we see a patient that's 10 years old or 100 years old. We're going to be reimbursed what we're reimbursed for an 0120. There is no wiggle room, right? So, and in that case, I would say you might want to look at your coding, because you may not be picking the most appropriate codes that could reimburse you better, but that's not my wheelhouse. Dental codes are not my wheelhouse anymore. In medicine, it makes so much more sense. We are paid on the complexity of the decision making of what we have to think through on a patient, the complexity of medical decision making. The dentist is paid to think. Okay, so that opens up a whole opportunity to bill more appropriately based on, is the decision making straightforward? Is it low, moderate, or high? Did they blow up your schedule? And that's time. Did they blow up your schedule? And now you're doing actually same day surgery. People, we're a mini OR every day, all day. And that's the one thing I feel that has happened with COVID is we are looked at so differently. I hope it doesn't change, but I see offices starting to revert back to old habits. Our PPE should have been in place a long time ago. You think about the splatter as a hygienist and a dentist, our assistants, that is happening in that room, and the aerosols. We are like a mini OR. There's a reason why we call it an operatory. So anyway, that's enough about that. But in our evaluations, we are paid on our complexity for medical decision making and time. Now that time now includes face time and non-face time. So doctors, if you are reading x-rays in your office before you go in to do your evaluation on a patient, that's part of that time. Maybe you're doing a treatment plan after hours, that's part of that time. We are paid on the complexity and time. That makes so much more sense than our coding that we have for dentistry and paid by dental. It's so limiting. This is what it looks like. We have new patients on the left. We have our time, our medical decision making. Then we go to our established patients, our time and our coding. This makes a lot more sense. Say a patient was very straightforward, but we spent, and they were an established patient, maybe they were very straightforward in our decision making, but we had to do a lot more counseling with them. We had referrals, we had a heavy medical history, whatever it might be, and they took us more time. We would actually upcode that based on the time and the complexity of decision medical. The timing would throw that up to, say, a low, say they were in our chair for 20 to 30 minutes or 29 minutes, but they were straightforward in our medical decision making. We would actually code it a 99213 or a 99203 for a new patient. Not always is it straight across that it's going to match up. So we're being compensated more appropriately for our medical decision making and our time based on the situation. I just feel like we spend so much more time with our patients than when you go to a medical doctor. Often we're not spending that much time with our providers, but they're not afraid to charge. And I've got some great examples about that. So this is where it's very, very different. And there's not a 1-to-1 ratio. There's a big myth about a 1-to-1 ratio medical to dental coding. There is no such thing. There are with certain things, but not, it's very sketchy when it comes to dental evaluations versus medical evaluations. So that surgical diagnostic coding, I want to focus on this a little bit more. Obviously, we can get reimbursed for our evaluations and our consults. So often I hear the word consult. Well, often I don't see practices charging for that because we give that away. There's a lot of stuff we give away in dentistry because dental's not going to pay for it, or we have these frequency issues with evaluations. Maybe they only have 1 or 2 per year. So we give that consult away. And truly we're not consulting. We're actually doing an oral evaluation. So it's an evaluation, not a consult anyway. We're doing a comprehensive medical history. Maybe we should be taking blood pressure. Maybe we're doing a PAN, a CT. Are we doing salivary testing? What about pH testing? A1C. What about coordination of care? All of these things can be built into our evaluation and our diagnostics. These are things that we can bill. So are we billing for it though? We're probably not, because we know dental won't pay for it. Something that we need to up our game on is our documentation. One thing that we at TIPS we teach is SOAP notes. How do we do a SOAP note? How do we do an operative note? SOAP notes, basically, there's the SOANP. I know in Minnesota, that's how we learned in hygiene school. We use SOAP notes. And the S is our subjective. What did the patient tell us when they came into the hygiene room? Why are they there today? The O is all the stuff we do to come up with the diagnostics. Maybe we're doing that A1C, maybe we're doing blood pressure, maybe we're doing oral cancer screening, maybe we're doing periodontal probing. All of those things go in the O. All of the things that we do to get to the A, which is diagnosis. What are our diagnostic codes that are making our evaluation medically necessary? And then P is what's our plan? What are we going to do? What's our plan? What's our aftercare? So SOAP notes are used for our evaluation and management. That's our evaluation management codes. Now, these are all the things that we teach with TIPS. And just so you guys know, as part of our partnership with Nobel, we are going to be offering to all of you that are interested a medical billing analysis, or an MBA. We're going to just call it MBA for short. So if that's something that you're interested in, feel free to put your name in the chat, or at the end, make sure that you reach out to me for that. But that is something. This is part of what we do, is that implementation piece. How do we get to SOAP notes? How do we create that so that everything that we're doing is medically necessary? Because what that's going to do is it's going to help you not only if you get audited by medical, but what if you get audited by dental? Now, here's a great story. I went into a practice and things were going well. The person who was doing the medical billing portion for the practice called me and said, "Hey, doc has got a great case. We just did a biopsy. He did a lesion removal." I'm like, "That's awesome. That's great to bill the medical." So I said, "Did he fill out an encounter form or a super bill for us so that we could bill that?" She said, "No." I said, "Okay. Well, that'd be the first thing, because the encounter form that we create and we put into a practice gives us the procedure codes and the diagnostic codes that we need to bill out, because the doctor's the only one that can choose those codes." So I said, "Okay, well, let's look at the note. Maybe the note will give us something." There was 3 words, 3. So everything happens for a reason. This became a great story for me to tell. Removed the papilloma. Nothing about the papilloma, how big it was. I was like, is there pictures? Is there anything? There was 3 words: remove the papilloma, remove the papilloma. We didn't bill that out. And not long after that, this doctor just wasn't getting the coaching part, and he just didn't want to change. He didn't want to do SOAP notes. He didn't want to do operative notes. And it made it really hard for us as the admin member that I was training to try to bill things out, because again, technically the doctor has to pick those codes, and he just wouldn't give us those. So documentation is really, really important. It's something that we work strongly on. There's definitely a clinical side and there's an admin side to this process. And we need to talk, we need to communicate. So SOAP notes, operative notes we work on. We also need to start getting our language better. We use a lot of slang terminology in dentistry. Implant. We actually call that when we submit our documentation to medical, it's a bone fixture or a surgical fixture. It's not called an implant. A panorex is not called a panorex. It's an orthopanogram. Bone loss. That's bone atrophy is what it is. And to what degree? Is it minimal, moderate, or severe bone atrophy? Abscess. Abscess is actually a cyst in the jawbone. It's an infection. We're so easily swayed by abscess. Well, what the heck is an abscess? It's infection. Like, let's get real about what it is and let's talk to our patients about what it is and let's document it appropriately. A crown and bridge. Now, doctors, I don't think that you went to a course in college, in the university, that was called crown and bridge. It was called fixed prosthesis or removable prosthesis. It was prosthesis. And so we want to start using that language. It's not called a flipper or a denture. It's an interim final removable prosthesis. So we want to start using that language in our notes. Now, it's one thing when we're talking to the patient. That's okay. But when we're talking notes, we really need to up our game. I see that all the time. Root canal, RCT, it's endodontic therapy. Our tooth numbers in medicine is a little bit different. Instead of tooth number and then the number, it's JP for jaw position 2 in this situation. CT, a CT it's not called a CBCT by medicine, it's called a CT. Filling, it's a dental restoration. So we've got to shift our focus and shift our journey in this process of what we're doing and how we're presenting this to medical to get paid. Because I hear this all the time. I just had a call before we got on this webinar from a doctor who has tried this. And he's like, I think we maybe got one payment. I can guarantee you they weren't doing these things right. And medicine's not going to pay you if you don't give them the right information that makes this process and makes the procedures that you're doing medically necessary. One thing that I do, one of the first things I do is incorporate a new medical history, because any of the dental softwares that are out there are not going to give you a comprehensive review of systems. This is really important. Medicine's going to expect to see a review of systems if they audit you. They want to see that you're going through the entire medical history. Super important, very easy to incorporate. I have some teams that actually put this into Yappy or some of the digital forms. That's fine. I think some of EagleSoft and Dentrex, actually you can create these as well. So medical history is really important. So again, what are we doing in this? Again, we're doing so many things. There's so many tools in our toolbox. Are we taking blood pressure? Are we documenting it, or are we just letting it roll? It's very important to do blood pressure, especially with surgical procedures, before we start giving anesthesia. We learn these things in school. There's a reason why we did it, but sometimes we get into clinical and we kind of let those things go by the wayside because we get rushed. When you're being reimbursed as a medical specialist, you have time to slow down and take the time to do this stuff, because the reimbursements are much grander from the medical side than they are on the dental. Are we doing a physical evaluation? Are we doing a head and neck eval? Often what I see in chart notes is OCS. But we're checking all of these things. Have a great piece of document that shows that you've done a head and neck evaluation, and document it, not only for your own documentation, but for legal reasons. We're seeing a huge uptake in oral cancer, oral maxillofacial cancer. Let's have great documentation that shows that we did a head and neck evaluation. It's very important. And what about A1C? Are we doing A1C? I see a lot of failed implants. When 1 in 3 adults is pre-diabetic, do we know that that person's pre-diabetic that we're doing surgery on? Maybe we want to do A1C. Maybe we want to make sure, because medicine really looks at the outcome. And, think about it, if you've had any type of surgery, they see you 90 days after, because they want to assess your outcome, and they redo your x-rays and your evaluation, and they do that 91 days post-surgical, because there's a global surgical package, and at 91 days they can see you and bill you for an exam and all the x-rays to go along with it to assess the outcome. So important to do these things ahead of time. What about my offices out there that are doing sleep? We do make a difference. Sleep is a huge opportunity if the patient has high blood pressure or they're diabetic, are we assessing for sleep? Sleep is very easy to assess, even if you're not treating it. And I get that. We can't do everything always in an office. We can't be great at everything, but are we assessing sleep? I can never get through a presentation without talking about that, because there's so many people walking around with sleep apnea. So are we assessing that? Even if you have to refer them to somebody else for a sleep appliance or a CPAP, that's okay. At least do the screening questions, the Epworth score. Are we assessing pH? pH is a big topic right now. Carrie Free has been doing an amazing job with this for eons, but a lot of people don't even know about their products. They've always had the medical mindset of we assess, we diagnose, we plan, we treat. And they have all the tools to help assess with pH and pH balance products to help our patients. Carrie's risk assessment, that goes along hand in hand with what Carrie Free is doing. There are codes. We do get fluoride treatments, fluoride varnishes covered using these codes for Carrie's risk. So again, I'm putting some things out there, maybe that aren't, this maybe isn't so much surgical. pH really should be, because implants can fail just like natural teeth. But I'm putting these out there so you really start to see there's so many opportunities in a dental practice for medical billing. With our PANs, this is a great one. As a hygienist, it drove me crazy that we had to pick between an FMX or a PAN every 3 to 5 years, because that's what dental paid for. Well, we all know that an FMX and a PAN are two completely different radiographs, two completely different reasons for doing, and they both hold just as much weight as the other. We're now able to bill to medical a PAN every year if we wanted to check for maxillofacial cancer. Now, out of all the things that medical pays for, I can tell you they don't pay real hot on PANs. The most I've seen is, well, I've seen more than this, and I'll show you an EOB, but on average, I think Medicare rate is around $20, but it's better than zero, because what I see offices doing is they're taking this along with the FMX so that they're covering all their bases, and they're checking. They've got the definitive FMX for diagnosing decay and things like that, but they've also got the PAN to help just check for maxillofacial oral cancer. Okay, so these are the codes. We'd use these codes, these diagnosis codes paired with the PAN orthopanogram in order to get a PAN paid for. So it's better than zero, because I see a lot of them zeroed out. Here is a EOB that was submitted as an established patient, level 4, at $175, an orthopanogram at $150, a CT at $575, and the interpretation of the CT at $150. So $1,050. Now here's a great opportunity to recognize that nothing went to, none was applied to deductible. They paid 100% of the allowed amount, except for $62. Now, does that look a little different than what you're doing now for your evaluations? I think this is a game changer in a dental practice as far as production and collections. So very different than what I see in most dental practices. If we start upping our game and really creating a medical model, as well as acting like the true professionals that we are, the oral physicians that we are, and charging for the things that we are doing instead of giving them away, because we have a way to get them paid for. Now, a little background on this EOB. My husband was in the hospital with COVID last August. Now, he went into the ER. He was in the hospital for 10 days. Fortunately, he's still with us. But very interesting with this EOB. He was charged $1,600 from the ER doctor. Now, I can also tell you on the same day, he was charged almost the same price, because physicians vary in their billing, but from a pulmonologist, an infectious disease, our primary care, and a cardiologist. He was billed around that same amount for a level 5 evaluation in the hospital. Our insurance, you can see, paid, $1,133. Now, again, I think we're underpaid for our evaluations because we look at all the time that we spend. We spend an hour with our patients in hygiene. We're doing a lot of assessment. We're no different in hygiene than a nurse and the things that they're doing. And doctors are billing this out and they're being reimbursed. So we have to start thinking and changing our mindset and shifting to more of a medical mindset. We deserve to be reimbursed more than what we are. But again, we've allowed dental benefits to really dictate what we can and can't get paid. All right. Here was another one, an inpatient consult, 110 minutes. Our provider billed out $495 for that. Imaging. I want to just double check. Is there any questions out there? Somebody had sent me a message that we were still disabled. Are we able to use chat?
Let me check. The chat is on. Last question was about Arrestin, and this question was, I'd say 10, 15 minutes ago.
Yes. Okay. I just want to make sure. I see everyone. Panelists can chat. Attendees can chat. Thank you, Lynn, for the test. I see yours.
Mhm.
Okay. I just wanted to make sure we weren't getting thrown off. Denise says, all good. Thank you. All right. So let's talk about imaging. I love this part as well. I get a little passionate about this. So sorry for all the stories, but there's so many opportunities within your practice. Again, as we go through this, if you're looking for coaching and, implementation of this, that's what I do. That's what makes practices successful. And we're going to be offering that MBA at the end here, that medical billing analysis, complimentary of our partnership with Nobel. So take advantage of that. Imaging. I can't tell you how many practices I see that get a CT and don't ever bill for a CT to medical. Now, most dental insurances will not pay for that. I love these images. I just started working with an endodontist. And if this doesn't scream medical and doesn't scream, oh my gosh, the patient could be on fire, and put us into more of a medical model, I'm not sure what will. This lower tooth, tooth number 19, you can actually see that infection on the CT trailing towards the mandibular nerve. Now, if that infection isn't going straight to the bloodstream, I don't know what is. I just thought that was such a powerful PA. Well, no, it's not a PA, it's part of a CT. But that's the difference often from a PA to a CT. If you're thinking about CT and don't have it, I can tell you, well, in this situation, we would have seen it on a PA. But there are, when I was training at this endo office, there was some PAs that we looked at that you could see a shadow, but when the CT, it was glaring with infection. So that's the difference between CT and that 2D image of a PA or a PAN. The other one on the right-hand side is sinus communication. Clearly that abscess has invaded the sinus.